Hi, everyone. How are you? You look pretty good for the end of what, 4 days now? I was listening to what Judy had been talking about, and I think she really deserves another round of applause. This is the kind of work that moves things like insurance forward. I was a dietitian for 20 years in the hospital, and I was allowed to write orders, and it just fills my heart to hear that it's going to be, an even playing field. So thank you very much. So what I want to know is how many MUIH people we have here. I didn't meet everybody. Yay! Awesome. Thanks for coming. So I'm delighted, honored, and very excited about this topic. I look back and I don't even know how I arrived here. I've been practicing for years and ended up giving a small lecture to 15, 20 students a few months ago, and that's usually what I'm used to. So this is a little frightening to me. Insurance, very, very complex. I will tell you that by itself it's complex. When we add in the changes that the healthcare system has been making, and for those of you who listen to the news on a daily basis like myself, I'm like an addict now. It's scary. You just don't know where it's going to go. How many folks here are currently accepting insurance, if any? Anyone? So, okay. We probably have 7 or 8 people. That's awesome. So you could talk on the panel today. How many folks feel that they do not know much about insurance? Well, that's good for me. That's great. I will be providing you basic sort of lay of the land, 101, if you will, fundamental orientation on accepting insurance. Trying to learn how to do this. Yeah, I'm a teacher. I can't figure it out. I'm hitting the button. There we go. So, yeah, okay, thank you. So I have no interest commercially or financially, but I will say that I'm also not an insurance coder or a specialist. I happen to run a small university integrative medical and health center at the University of Maryland, and I just hired my own billing and coding specialist about 4 weeks ago. So if you have any detailed question, don't be surprised if I can't answer them. That's why I hired her. We will talk about the big picture, though. So today, we'll explore a little bit about the healthcare and insurance landscape and how it may affect the nutrition provider. We'll identify some insurance payer options, not all, but some within the time we have, and fundamental of the insurance billing and coding. So we're going to talk about the infrastructure of how billing and coding goes. And then we're going to talk a little bit about the steps to become an insurance provider. And at the end, we'll summarize and we'll talk about the pros and cons. And of course, along the way, give you some resources. So I think everyone here would agree that we've got a problem of affordability. How many people here have been affected on a personal level with rising costs in their deductibles? That's almost like everybody. And so over the decades, the cost of insurance has steadily increased for both organizations and consumers. The 2 main causes, the way I see it, was the increase in the governmental policy that happened years ago. We call it Medicare and Medicaid. And also, people's poor lifestyle really has had a negative impact on our cost over the years. We've created a higher demand for ourselves when Obama ACA, which is Affordable Care Act, was enacted, I think, 2011, has provided a lot more preventive services. The plan also mandated that every American have coverage, so our volume of patients has greatly increased. And so the volume of patients have really gone up, and so have the health care plans. The sick pool has gotten sicker. with the addition of populations that couldn't afford care now have health insurance plans. In addition, our population of seniors is growing, and the baby boomers who are retiring were expected to double the Medicare and Medicaid costs by 2020. Sounds pretty grim. There'll be some sunlight here, though. As a result of all this, a lot of costs have been shifted to the consumer. The share of the burden of the American healthcare and just the individual cost have shifted over the recent years to the consumers. The amount of out-of-pocket money that an insured individual and family pays now before insurance coverage really kicks in is something that we've never seen before, and this has become the norm. Deductibles are very high. And then we have the repeal of Obamacare without replacement or with. No one's really sure yet, which we can't really comment on at this time. All of this has created a huge demand from the system itself, the healthcare organizations, consumers, and the healthcare plans. We're seeking plans. We are seeing healthcare plans playing a leadership role in working through new arrangements to support more quality and affordable care. The companies are trying to empower the consumer by allowing the price transparency of health plans. Years ago, a consumer did not know what they were going to pay, and now you can go to any internet site and see that it's all out there. There's a lot more electronic health records, not only to make business more efficient and improve costs, but to provide more interactive patient portals so patients can become more interactive and more empowered. The allowance of more telehealth communication is taking place to improve the accessibility of care. And outside, the organizations, they're merging. Single practices are leaving. They're being folded into hospitals. They're becoming employees, or they're joining larger group practices. As this environment changes, it changes for the provider as well. And although the challenge of affordability remains, there are some bright spots, and I think they do exist, and there's some on the horizon, and so we'll talk about some of those. The Affordable Care Act started at 2010. It really didn't get going until around 2013 and 14. And with the help of Obamacare, a major shift started. We changed our paradigm from treatment to prevention, and this was around 2014. The plan also mandates that all insurance companies, whether government or private care, has to cover preventive care, and for free. So we'll be discussing this a little bit later in detail. Also, the shifting from the volume-based model as we know it to the value-based model started. And we started beginning to depart from a long-standing fee-for-service. In other words, it's moving away from our insurance companies rewarding our docs and other healthcare providers through the number and types of procedures provided. So by value, we're speaking of quality, and we're speaking of a better price. Accountable care organizations is one of the areas that has really, really grown. I think in 2011, we had about 60 accountable care organizations, and now to date, we have around 900. And this is sort of a newer model. It's mainly primary care based, but it includes quality teams, more of an integrative approach. And the teams include home health, dentistry, therapy, and nutrition counseling. The last thing, but not least, there's a lot more, is alternative payment models. Combining existing health insurance plans with out-of-pocket service models to provide not only a relationship-centered and customized plan, but to reach those populations that a provider may not ordinarily serve, and also to enhance the clinician's practice in volume. So I thought maybe it would be important to include some alternative payment models. There's really some good evidence out there that providers are moving to a mix and sort of match, if you will. They're models. They're not choosing one. They're choosing usually two. And last year, late 2016, there was a study that came out. It was by Cario, who's one of the leading EHR companies. I don't know if anyone's heard of that. We almost chose Carrier, but we ended up going with someone else. It was called the Practice Models Perspective Survey. They conducted a survey about 800 practice managers, clinicians, owners who were working in solo and in small practices and who were interested in testing alternate models. They found out at the time that 30%, and this was about a year and a half ago, 30% had already switched over to an alternative type of payment models, and 70% wanted to really move out of being covered by insurance 100% of the time. So some of these particular payment models are used in integrative healthcare setting, as you probably recognize. And it's important to realize, though, that the payment model alone doesn't represent the whole business model. For those of you who might be new in the world of nutrition, you know, the number one challenge for all of us is recruiting patients and referrals and keeping a steady source of referrals. And you have to consider the other side, and that's that financial burden. So this model really takes care of the payment method, but it doesn't take care of the models that's going to handle your finances. So you have to think about, do you want to be solo and pay for everything by yourself? You want to do a co-op type practice model where there's 2 or more people involved? Or do you want to do a group practice model where other providers offer services to help pay for your overhead and bring in more revenue? That is the model that we chose in our clinic. We have, mass advertisements out right now, and we are probably advertising for 6 or 7 different practitioners. And so, you know, we have a ways to go. We're starting to accept insurance this spring. We'll be accepting it for nutrition professionals, and also, and you know all of our students are CNS bound. Also acupuncture, which are the 2 big reimbursable services in Maryland from our concern. So the first payment model is direct pay with a super bill. And this is the traditional, everyone's doing it. You know, this is when your client pays out of pocket. This self-paying person, you know, they're part of a growing group that often opt out now of premium healthcare plans. They go with the bare bones, they go with the catastrophic plans, the high deductibles. A lot of your millenniums are doing this. The provider should include a super bill to the direct pay model. It not only allows your patient to file claims directly, but it also allows you to have some returning patients and some attracting new patients. You know, if people get reimbursed, they come back. The next model is third-party pay. This is, you know, your insurance. Your typical MD, doctors of osteopathy, DC-based practices work with this model. It seems to work when you can see 30, 40 patients a day. Probably wouldn't be good for the integrative healthcare provider who wants to perform a 90-minute consultation. And you know, the majority of the schools out there, like us, who are academic, I think there's 60 plus schools, they're basically on a 100% insurance, a lot of the schools, particularly out west. And they're just not making it. They're not making money. In fact, some of them are losing. But you have to understand that their mission is very different. So I don't look at this research and say, you know, insurance isn't going to work. They have huge overheads. Their mission is very different. They're in the business to recruit patients for student practice. And so that wouldn't be our mission in small private practice. So just keep that in mind when we move on and talk about these other payment models. The membership, I'm sure a lot of you heard about the membership. It's kind of like a gym membership. Your clients pay a monthly fee. They range anywhere between $50 and $200. And it's up to you as the provider to create what kind of services you want your client to have. Concierge service, basically it's been around for a long time. Many docs in larger, affluent markets started moving into this direction before the recession. A lot of them have closed since, we've had some economic issues. And the payments are a lot larger, and they're usually paid annually. And then there's the hybrid. The hybrid's just come out in the last, 10 years. And I think in integrative medicine, it's really been strongly talked about just in the last few years. And the hybrid is a combination of direct pay and third-party pay. It seems like the organizations who either have a membership or direct pay or a combination of the two are still doing well when they institute third-party pay. At a smaller amount, but this keeps up your referrals, this keeps up your volume, and like Dana said in the beginning, it serves as really good outreach, especially for the people who are underserved. The Affordable Care Act, if you don't know, and you probably all pretty much do about what's in there, it's required coverage. So when we talk about private health insurance plans today and governmental plans, realize that it's a requirement for all of them to contain the ACA mandates. So they all have nutrition and behavioral counseling for more chronic conditions. These are specifically obesity, and in the past, obesity was never covered. Diabetes, chronic kidney disease, and cardiovascular disease. Behavioral counseling is something new. Now they're offering behavior counseling for overweight and obese individuals, particularly if they have an additional cardiovascular disease risk. And we have preventive screening now in obesity, diabetes, hyperlipidemia, and bone health. And if any one of those screens are positive, they get referred to a nutrition provider. There's programs now, we'll talk about these in detail, but they're centered around obesity and diabetes and an annual wellness program. So the private commercial payers, there's probably about 35 private health insurance companies, only 35 companies in the country that serve the American public. And these are the 5 that probably hold most in the market. We have to realize that they're publicly traded companies, they're independently operated, and at the end of the day, they're looking to generate a profit for their shareholders. And because of that, they're very independently operated and run. Each state has their own sort of business, their own nuances. Therefore, there is no uniformity between insurers. And so as a provider, when you're interested, and you're maybe want to look into insurance, you really have to call the companies and the plans direct. It's important to know that these companies have a multitude of health insurance plans, so it's not the company. Rather, it's the plan within the company, or plans in this case, that actually determine the insurance. Commercial product lines will usually reimburse at the highest level. And then in terms of the reimbursement rates, really difficult to tell you that today, because I know that's a lot of questions. Well, what do you think I'll get? And it depends on a lot of things. It depends on your fee structure, your own fee structure. What we are doing here now at Maryland University is we've realized that we were underfeed with our services. We had to raise our fees, and if you need to raise your fee, you have to do that so many months in advance before you even apply to become an insurance provider. They also look at the fees around you in your regional area. So if the people around you are making more money, it may end up that you get more reimbursement than what your fees are, or it may end up the opposite. And when you actually contract with the company at the end, the insurance company, it really matters on how well you negotiate and what you get for a percentage. So the average percentage is somewhere between 75 and 80% of your fee. If you get 85%, that's the best you can do. We're hoping for 80, and we're a pretty large establishment. The criteria for private insurance reimbursement, well, it either has to be face-to-face, which means in person, or telehealth. And insurance companies are doing telehealth. It either can be one-to-one services, or it can be in a group service, 2 or more people. But it has to be considered medical nutrition therapy and or counseling. And you can just look, what those definitions mean. But these are the buzzwords. If you look at coverage, you see a lot of nutrition counseling all over the provider's contract or in their criteria. And this is where it gets kind of crazy. So there's more criteria. A lot of companies are condition specific. With the acceptance of Obamacare, obesity is considered now as a condition, so that's sort of, something more. But they look for conditions that are very evidence-based. Chronic conditions such as diabetes, hypertension, hyperlipidemia, CVD. But there are some companies, like currently Aetna, will not cover for asthma, chronic fatigue, or fibromyalgia because they do not consider it at this time enough evidence related to food and therapy. We have to consider the different plans, although it doesn't affect us a lot, only with referral systems. So a PPO plan is probably the most flexible plan for both consumer and provider. The provider doesn't have to worry about having to have a referral or any kind of authorization, so there isn't any primary care gatekeeper. Where in an HMO, it's more managed. It requires a PCP to be able to coordinate care. The good thing about a HMO is that it's higher prevention because it's a maintenance type plan and they really want to cut costs, so they're very much into prevention. The POS plans are sort of a hybrid of an HMO and a PPO, and unfortunately they require a PCP to refer to. So you'd really have to, wait for that in order to get that referral. There's tiers. You heard of the metal tiers? There's bronze, there's platinum, there's gold, there's silver. There's a lot of different plans within a plan, and the good thing is the Obamacare actually is in all of these plans at the same level. As far as the other option you have, it's public and government payers. We're talking Medicare, Medicaid, veteran programs. Probably Medicare is the most used for CNS folks. And, they are federally controlled, so their plans are pretty standard. So you can go from state to state and expect the same plan. What you cannot expect is the same price. Even though they're predictable and they're flat prices, they do range. I think right now, for the 2017 for Medicare, it's somewhere between $28 and $39 per 15-minute unit. And so a nutritionist has to claim, their office visit and units, and we'll teach you how to do that if you don't know. The reimbursement for government is the same as it is for private care or private pay. And the only different thing is that they do telehealth, just like insurance for private pay do, but they're a little bit more restricted with their telehealth. They reimburse specific conditions only, and those are diabetes, type 1, 2, and gestational. They also pay for a larger program. It's the Outpatient Diabetes Self-Management Training Program. It's sort of a hybrid of single visits and group visits. And the goal is to have the patient become a lot more empowered, taking their own blood sugars, managing their own, looking at their own weight. A diet or a nutritionist can, actually help run that. There's IBT therapy for obesity. And this is sort of a screening system. They'll screen adults. If their BMI is over 30, they will get immediate counseling and behavioral therapy. And I missed chronic kidney disease. This is something I did probably 20 years ago, and that was my bread and butter. I had insurance. I was a provider, and this was my niche. I had teamed up with all the Mid-Atlantic nephrologists, and I had an absolutely booming business. If you can find a niche and use something like Medicare, I think you might find it worthwhile. Annual wellness visit, that's for seniors, usually over 65. Medicare covers it, and it's kind of neat. It basically screens their cognitive wellness, it screens their high risk, if they have any, blood pressure, weight, and then nutrition is included if, the screen is not very healthy. This really is not a separate category, but I wanted to mention it because supplemental insurance payers, it's usually a person who carries two different kinds of insurance. Supplemental or secondary insurance is a coverage that is available in addition to primary healthcare insurance. I think, people who carry Medicare, you probably carry this. That's more of the common uses of it. Medicare only covers about 80%. And so a lot of people pick up a secondary payer. It can be either private or it can be another government type payer, and they will pick up the 20% hopefully. And it's good for us to know that because you want to ask if they have two insurances to maximize your own reimbursement as a provider. Telehealth and reimbursement. Well, basically, these two terms can be used interchangeably. They have, although I'd say telemedicine is the older of the two. It's centered primarily around physicians and their patients, clinical care. Now telehealth is the more universal term for the current broad array of applications in the field. Home health, dentistry, physical therapy, and definitely nutrition. CNS, RDs, both can become providers for telehealth. And the technologies in this country are more centered around the live video. It has to be real time, has to be interactive, and usually through audio-visual. There's only 2 states, I think, in this country. I think it's Hawaii and Alaska that allow pre-recorded videos. Who pays for telehealth? Private payers. They're increasing their reimbursement overall. I guess how much and which telehealth companies or services private payers pay, really varies state by state, kind of like the private insurance in general. And so while the trend is toward broader coverage of telehealth services for plan enrollees, private payers are still deciding exactly what to cover and how they cover and what they shouldn't cover. So it's still an issue, and it's not universal everywhere. I can tell you that approximately 30 states right now, including the District of Columbia, has passed a telehealth parity law. Parity laws are a mandate that private payers in those states pay for telemedicine or telehealth services at the same rate as the face-to-face visit. Medicare pays for telehealth also, but only under certain circumstances. Medicare will pay for telehealth services when the patient is located in what they call a health professional shortage area, basically a rural area where services are scarce. And again, HIPAA compliance, very, very important. Most people think, the technology has to be HIPAA compliant. Usually where the problem lies is with the people who work the technology, and we'll talk about that in a second. So billing and getting paid, a lot of steps. And if you're like me, I absolutely hate paperwork. There's a check-in, you have to find out if your person is eligible and verification, and you may choose to have a billing specialist or an assistant come in and do some of this. What we find in our office is the front desk does the patient check-in, the insurance eligibility, and verification. And then the actual practitioner does the coding of the diagnosis when it's there, procedures, and the units, and of course the progress note documentation. And then the biller comes into play and does the charge entry, does the claim submission, and actually posts the payments when they arrive. So these are the steps. The diagnostic codes, they come from an IDC-10. And I think about 2 years ago, they renewed themselves. They were ICD-9, used by physicians. As we said before, payers recognize the chronic diseases usually. But if you're smart, you can call ahead of time or have someone call ahead of time and check to make sure that the disease or condition can be covered. CPT codes are the other part that you have to know. These basically are your office codes. And these two office codes are the ones that people bill the most. The first one stands for the initial, the second, the follow-up. And if you end up having telehealth in your state, you take these codes and you attach GT after the codes to be able to submit for reimbursement. These are some additional codes. These are your government codes. The top is for the individual, one-on-one, and the rest are the actual programs that we talked about. Number of service units, it has to be direct face-to-face. I don't think we have this issue because we're counselors, but if you're an acupuncturist and you go into the room and you talk to your patient for a while, some acupuncturists might insert needles and then leave for 30 minutes and come back. That 30 minutes cannot be billable. We don't have that issue, so we're face-to-face with everyone. But any kind of pre or post-visit activities aren't billable. So if you're gabbing with your client, before and after, even if you're in the room still, you cannot bill for that. And so each unit is 15 minutes. They come in 15-minute increments, and they also come in 30 for group services. So if you had 1.5 hours for your first consult or your first initial visit, that equates to 6 15-minute units. Proper documentation, so important. Legal documentation serves both clinical needs, as we know, but it also substantiates the services and items billed on the claim submitted. So your note has to contain information that coincides with the codes claimed. So in other words, if a client came into you and they had IBS symptoms, but initially they came into you for CVD or hyperlipidemia, in order to claim that hyperlipidemia, you could not document and take care of the IBS. It has to all match. Now, you can take care of the IBS, but somewhere in the note, you really have to talk about and focus on what you're actually sending the claims department. You have to list your face-to-face time on the actual note, and then any kind of incomplete or illegible records may result in denial. What we're probably going to do in our establishment is send our notes with a lot of our claims, and you have the option to do that. It just sort of reinforces our new biller. That's been her past practice, and she's had really good luck with optimizing insurance for the orthopedic surgeons in the orthopedic office that she worked in prior to us. But it's not mandatory. But if anyone asked, if the insurance company asked, you have to have a note that really dovetails with your codes. These are the two forms. The health insurance claim form, it's called a CMS 1500. That's the insurance form that every provider or vendor will fill out and send to the insurance company, either electronically or paper. The bottom is a typical super bill, which you would use if you did not do upfront insurance like this. If you're just doing out-of-pocket, direct pay, self-pay, you'd have this. But you also have it even for insurance, because this is something that the coder or yourself or the insurance company will need with all the information. Paper or electronic billing? Well, I hate to say, but it's not the first choice from the insurance provider's eyes. But it is for many of us because we're small, we're still in the paper mode, and it's okay. As long as you realize that when you mail it, it's really difficult to tell where it landed. It takes a few days to get there and up to 45 days to process. Most of larger insurance companies will use electronic claim submission, and it cuts down the turnaround time by half. And the reason for that is as soon as you push the button the same day that you've seen your client, the claims are submitted immediately to the insurance company. The electronic health record, how many people have one? Okay, less than half. Third-party payers use EHR to expedite communication and services. This definitely decreases the time and costs. It also is more timely and efficient, but they have built-in systems which are awesome. We're just leaving our paper and we're going to an EHR this spring. And for us, it's been sort of a nightmare. We're really kind of big, so we have a lot of things to do. But for us, we are going to be able to track our reimbursement deposits. Otherwise, you have to do that by hand. Codes are built in, patient statements are built in, your diagnostic codes, your CPT codes, everything is built into the actual software. So it's really, really nice and efficient. HIPAA compliance is something that, you know, as an insurance provider or just as a provider is really important. And I know a lot of us, I teach this in class at the university, and we always give this survey to the students. And they're like, I'm HIPAA compliant. And you give the survey, and it ends up that, you know, they're not doing that well because there's a lot of little nuances that we normally don't talk about. Back in 1996, it formed, you know, this basically is a law at federal level and at state level. And sometimes the state level precedes the federal level, like in Maryland. We have more stringent laws. Specific populations or protections to safeguard protected health information. PHI, it just means protected health information. That's in paper form. EPHI basically is electronic. And so, you know, make sure that your files are kept locked and unattended and all the things. You can actually go to the site. You don't have to have me tell you those things, but it's very, very important. Using a billing vendor. So professional billers submit claims, as we talked about, to all insurance. Sometimes they come with a great software package. They can, you know, provide you other things like revenue cycles, either weekly, monthly, quarterly, annually. And there's different terms of payment. If you end up negotiating with them, and it is negotiable, percentages of the total amount collected, the ranges that I've seen are anywhere as low as 5% all the way up to 15%. A lot of our acupuncture students collect insurance when they graduate, and you know, I think they pay around 9, 10, 11%. You can either do that, or you could do it by volume of practice, either in the number of claims filed or paid. Up to you. Becoming a provider, lots of steps. And when you do some literature searches on how to do this, they really only talk about credentialing and contracting. I think it's really probably important to talk about the things that you need prior to credentialing, otherwise you won't be able to get to the credentialing state. Having a business plan, deciding on your payment model, becoming licensed, if required by your state or certified, and forming a business entity. A lot of students, when they graduate, become new nutrition providers. They want to use their social security number, and we basically discourage that greatly because you want to protect your own identity. An EIN number is a tax ID number issued by the IRS, and it's probably a lot safer to use that because that number will go on your claim forms, and you know, it just keeps your identity really safe. After you've done that, you want to register for an NPI number. An NPI number is also a single identification number, but it's issued from the federal government, yes, but it's issued to you as a healthcare provider. So this is your healthcare provider number. So now you have a tax ID number and a healthcare provider number. Once you do that, you should have liability insurance. You will not be able to get through the credentialing process without it. And again, lawful HIPAA compliance. The credentialing process itself is not fun. I can tell you in advance, it's long, it's kind of painful, but once you get through it, you're good to go. So facilities and providers must be credentialed. CAQH is the Council for Affordable Quality Healthcare. It basically provides an online service that collects provider credentialing data. Let me clarify though, we're not talking about credentials after your name, we're talking about the credentialing of the actual insurance companies. And you know, they verify your credentials, they verify your education, your experience, specialty, malpractice, and this is where you want to shine with specialty. This is the beginning of forming negotiation with your contractor. If they feel that you have a really viable specialty around the region, you may get a higher percentage contracted. They also they ask for letters of recommendation, very much like getting into college. And the credentialing is really long because it's one application for many different companies. You know, you have a choice. You can go to each company and you can apply over and over and over again, but we don't recommend it. Once you get into the CAQH, you're in there, and it's just a lot easier for those of us that are doing it. And you know, it takes about 90 days, so be prepared for the worst case scenario. Contracting process, you cannot go forward until you've been approved by the credentialing department, and this is where you'd start contracting with your companies. Now, when you do the electronic form, this might be too much information, but a lot of times companies such, I think it's United and an Aetna, they'll pop up early when you're actually doing the electronic form and you're still in the credentialing process. So you might be able to start early. This process takes about 180 days. Now, there are some challenges in some states. Your state may not credential, or the lack of licensure, sort of what Judy was talking about earlier. Or your state credentials, but the insurance company does not offer the nutrition benefit. I don't think that exists a lot like it did even 10 years ago. The insurance company provides the benefit, but there is no room to accept you. And so they will tell you, come back 3 to 6 months. We just got a turn down for acupuncture through United in our area, which we're in the Laurel area. We haven't started with nutrition yet, so I can't tell you any news on that. So to summarize, the pros and cons of accepting insurance, well, insurance coverage is usually dependent, you know, on diagnoses, and varies between insurance companies and among individual policies within any given insurance company. So there's a lot of nuances. You know, we already know it's a lengthy process. We know that insurance companies have, you know, individual type situations that you have to learn. You have to have the patience for that and the want to learn. Not all companies recognize nutritionists, although again, I don't think that's very prevalent like it used to be. Reimbursement contracts offered may be unreasonably low. And then third-party payment model, the insurance model, and again, we're not talking about the full insurance, we're talking just partial, you know, doing sort of a hybrid approach, may not fit your idea of what a consultation should be. You may want to take more time, you may want to have more patient-centered, more relationship type, and that's up to you. The commercial rates might be unpredictable, but they do become predictable after a while when you work with them over and over. And then there may be uncertainties with the repeal of Obamacare. On the brighter side, depending if you're half glass full or empty, if you want and your vision is to offer more affordable care and reach, as Dana said, the masses, serving the community, including the underserved, this could be for you to integrate in with what you're doing. It may allow you also, like myself, to focus in covered specialties, and it definitely will help you sustain more of a referral base. It may boost your credibility. You know, physicians and insurance companies will get to know you. And because nutrition counseling is widely covered by many insurance plans, it's moving into the prevention area, which is really good for us. It does bring, although it may not come from the right place, but it brings a lot of loyalty and retention from your clients. And it does increase your marketing. So you have to align your practice with your ambitions, your vision, and your mission. Thank you.